and we'll get going with that.
Is this your full panel? You all set?
Yes. Yep.
All right, well, good afternoon, everyone. Man, that is a tough act to follow. Brian, good luck with your panel. And where's Rita? Rita, again, thank you for helping us all make our mark today. So we really appreciate it. I am going to steal that, just so you know. So in all seriousness, it's my honor and pleasure to introduce your next moderator, Brian Frazee. Brian Frazee is president and CEO of the Delaware Healthcare Association, which represents the first state's hospitals, health systems, and healthcare-related organizations. With a proven track record of engaging key leaders and stakeholders, he is poised to lead the Delaware Healthcare Association into a new era of innovation, collaboration, and excellence as Delaware's healthcare landscape evolves. Brian brings a unique blend of political, policy, advocacy, and association leadership experience to Delaware and to the DHA. He most recently served as Vice President of Government Affairs for the Maryland Hospital Association, where he led advocacy efforts on behalf of Maryland's 60 hospitals and health systems at the local, state, and federal level for over 8 years. Brian did give me a 35-page PowerPoint for his introduction, but I was able to pare it down just to that. So Brian, thank you very much.
Thank you. Good afternoon, everyone. Mark, thank you so much for that kind introduction. And I was also going to say that I hope that this panel makes its mark. So that clearly is going to be a thing, Rita. I think Rita just stepped out, but that was quite funny this morning for that panel. And Dr. Melnick, thank you so much for such a great presentation. As the dad of 3 daughters on National Daughters Day, I can definitely relate to both the young girl at the end of the video, but also the terrible twos slide, because my youngest is 2. So. In any event, in all seriousness, thank you all so much for the opportunity. I did want to take a very brief moment of personal privilege to thank Tim Gibbs and all of my colleagues on the planning committee for this event. It's been a great opportunity to connect with so many colleagues, friends, members of my team. McNamara Williams, is with us as well and helped me assemble this panel. So really appreciate the opportunity to be on this stage with so many great healthcare leaders, and really looking forward to hearing about all of the things that they have to say today. So I'm going to provide very brief introductions for them, and then allow them, of course, to introduce themselves. Just so you get a sense of kind of the flow of this panel and what it's going to be, we're first going to start our focus on what they're experiencing within their own institutions and industries. We have a diverse set of healthcare stakeholders here between hospitals and long-term care, home care. So we're going to kind of start at that more specific level about what they're seeing, where they feel like things are going with their workforce, what's working, what's not working. Then we're going to talk about the future of the healthcare workforce, both in how do we develop the pipeline, what is the impact of telehealth and generative AI going to have on the future of the workforce. Then we're going to talk about how we can work together. We, of course, all know what's working in our own hospitals and organizations, what's happening in our own industries, but how can we all work together across the continuum to advance many of these efforts? And then finally, as you all know, we have a big election coming up in November. And for those of you who don't know, we will actually have the largest turnover at one time of elected officials in our state's history. So we have a lot of unique opportunities to work to advocate for all of what we need to support the workforce, and in turn our patients and people that we serve in the future with a new administration and new legislators and whatnot. So without further ado, I'm going to introduce our esteemed panel here. First, we have Sue Getman, who is the Executive Director of the Delaware Association for Home and Community Care. We have Dr. Jeffrey Hawtof, who is the Director of Provider IT and Medical Education for Beebe Healthcare. We have Cheryl Heiks, the Executive Director of the Delaware Health Facilities Association. Jessi Rhoades, the Director of Talent Acquisition at ChristianaCare. And last but not least, we have Rosi Wurster, who is the Senior Vice President of Patient Care Services and Chief Nurse Executive for Bayhealth. So if you all would, one by one, we'll start with you, Sue, kind of go down and tell us a little bit about yourself, your role, and also what is your why? What really drives you in this work and brought you here today?
Thank you, Brian. and good afternoon. As Brian said, I'm Sue Getman, and I'm the Executive Director of the Delaware Association for Home and Community Care, or as we're known by our acronym, DOC. My background includes 25 years in leading Delaware Senior Centers, the Delaware Aging Network, and working with the Stand By Me financial coaching program in Delaware, as well as working with the National Institute of Senior Centers. DOC is an industry association for licensed providers of home care services, including skilled nursing, hospice, home health aides, and personal assistance. You may be interested to know that there are more than 120 active home care licenses being used by providers throughout Delaware to support our most vulnerable residents. The association offers resources, education, individualized support, networking, and advocacy for public policy and Medicaid reimbursement with state agencies and state government. The actual reason I'm sitting here today is that when I looked at the announcement of the summit, I contacted Tim Gibbs, the conference chair, and said, Tim, the Healthcare Workforce Summit agenda looks awesome, but I don't see home care anywhere on the agenda. So be careful what you ask about, or you may end up on a panel. I really do appreciate the opportunity to represent home care this afternoon and talk about the vital and essential services our sometimes invisible workforce provides, which enable children and adults to live where they want to be in the place they call home.
Okay. Rosi?
Good afternoon, everyone. My name is Rosi Wurster. I am the Senior Vice President for Patient Care Services and Chief Nurse at Bayhealth. And thank you previously to others here who have presented. My brain is really packed, and so is my notebook. So it's been a great day. Bayhealth, you may know, is the leading health system in Kent and Sussex counties. We have somewhere around 5,000 employees. We have two main hospitals for inpatient care. In addition, we have two freestanding emergency departments and a very large ambulatory platform in our southern two counties. We are a magnet-designated health system, which is the highest patient outcome level achievement it's a nursing award, however, a health system achievement. And we serve as a major employer also in Kent and Sussex counties. We have presence in the development of those who would like to work in healthcare and provide service really throughout that whole region. My why. I've been a nurse for 27 years. I've been an executive nurse for the last 10 years, and my heart is in taking care of the people who take care of the people. Part of my responsibility, along with the senior team, is to create a work environment so that our clinicians and team members can be there where our community trusts us to be, so that they don't have to think about, I have an emergency, I need to go to the emergency room, or I need to see a doctor, I'm going to Bayhealth. And I became a nurse because I love the intersection of science and people. And what I find now, which is really applicable in the topics we're discussing today, is that the care of that workforce is really critical to how we care for communities. So I look forward to our discussion.
Good afternoon, everybody. I'm Cheryl Heiks. I'm the Executive Director, Delaware Healthcare Facilities Association. We are the nonprofit trade association for long-term care in Delaware and have been, not me, but the association has been doing this role since 1963. I've been doing it for 5 years and pleased to do so. Before that, I've been in government relations and legislative activity, mostly in Dover. And throughout my career, my emphasis has consistently been on workforce development. So I know I sound like a broken record, but I've been very, very anxious to be here today and to share with all of you how important workforce development for our healthcare industry, for long-term care certainly, for our hospital partners, for those in home care, and across the board. We have a supply problem. We have a huge need. We are upside down, certainly in long-term care when it comes to the supply and demand. And we're not going to change this if we continue to be operating in a silo. We'll support this group this year, and then we'll support that group next year, and then we'll support this group. We need to be looking at it as a collective and be speaking from the same song sheet, as they say. So that's why I'm here, and it's a pleasure to be here. Thank you.
Good afternoon. Yes? Okay. I'm like, how close do you have to get this thing? My name is Jessi Rhoades. I am the Director of Talent Acquisition for ChristianaCare, specifically for our home health, acute care, and campus-based operations teams. I am also a nurse. I've been with ChristianaCare for 15 years, and I call it the dark side of HR. It's really not that dark over here. But I've been with HR for about 6 years, and it's been a really lovely kind of collection of all of my past experiences. I have some background in allied health education in the state of Delaware. As Scott mentioned earlier, I now am a member on the Delaware Workforce Development Board. And so it really is wonderful. I was also born at ChristianaCare Hospital. So it's really full circle to kind of, I guess I didn't really get that far, but I am passionate about this community and understanding how we can continue to bring health to our community. And I think that all of what we're doing today is really a step in the right direction. And it'll probably come up later on the panel, but it's so lovely to understand when you think about what you want to say and you come and you listen to all of the panelists before you and the speakers before you, and you're like, well, I guess I can just go home now because they said it all, right? So it's really nice to be aligned in a room of people who have great ideas and great thoughts, and I'm honored to be on this panel with this amazing group of people.
Good afternoon, everybody. It is a pleasure and a privilege to be here with all these great people. My name is Jeffrey Hawtof. I've been a practicing family physician in Sussex County for almost 30 years. And I currently am the medical director, or the director of medical education. Had worn a hat before as their chief medical officer for 10 years, worn many hats. But not only do I practice family medicine in my own clinic, I also work at assisted living facilities, do a lot of geriatric medicine as well, as we've been here today. Actually, a U of D grad. And what brought me here today is my patients. I get to every day, probably 10 times a day, hear all of the workforce issues that we have in healthcare from my patients, whether it's nursing issues, dental issues that they have problems getting in to see, long-term care issues, just simply getting into a specialist, or the one that really digs a deep knife into my heart is when they say, it took me 9 months to get in to see you. And I'm just like, I wish I could work more hours, but I do need some wellness. And so those are what brought me here today, and really just to learn from you all. So.
Great, thank you all so much. So we're going to kind of alternate here, start with Rosi next. If you all could talk about, what you're seeing within your hospitals, and Sue and Cheryl, what you're seeing within your own industries in terms of issues and trends, what's working well, what's not. And Rosi, not to put you on the spot specifically, but there was a lot of conversation this morning from Representative Minor Brown about the unique partnership that Bayhealth has with UD, so I'm sure the audience would love to hear just a little bit more context about that as well, if you're willing to share.
I'm happy to start. Thank you. So when we look at answering the question, what are we seeing, we have demonstrated that throughout the day. I think our care settings, our practices, we're all experiencing vacancy, we're experiencing turnover, we are experiencing some differences in generational elements of our workforce, and really amplified today. Two of the very important things for me to share in this vein today are the value of partnerships and how partnerships have evolved over time. When I was beginning nursing, I remember my clinical background's emergency nursing. Partnerships were, where's my patient going to go next? Are they going to a unit within the hospital? Are they going to be going to long-term care, rehab? Are they going to have home care? And those partnerships are still critically important, but haven't we grown? Now we have partnerships with benefits providers for wellness for our teams. We have partners with insurers. We have partners with legislatures. We have all of these dynamic partnerships. And one that we talk about quite a bit within the nursing zone is how do we connect our academic leaders, our academic practices with the operational arm, academic and practice partnerships. So what Representative Meyer-Brown was talking about earlier was a project where Bayhealth and University of Delaware have come together. The School of Nursing and the Patient Care Services Division at Bayhealth. We've created what we call the Scholars Pipeline Project. It has two prongs. The first you heard about, and that is we engage a senior nursing student. At the beginning of their senior year experience, we give them a stipend from Bayhealth, where they then commit and agree that their senior year will be all of their clinical assignments in Bayhealth environments. That includes women's and children. It may include some outpatient. It's primarily medical surgical nursing experience. Then that individual transitions right from being a senior nursing student into being a nurse resident at Bayhealth. We have a one-year ANCC accredited with distinction transition to practice program for nurses that leads them in a prescriptive way, gives them set experiences and a cohort with which to travel through their first year as a nurse. Then the final phase is their second year as a nurse, where they are then a seasoned scholar, and they are remain in the commitment with Bayhealth. They're now a Bayhealth employee, and we can then open up any kind of clinical opportunity that nurse would like to participate in, whether it's a practice change, whether it's inpatient, outpatient, population health, anything they've learned along the way, we can provide an experience for them in that third year. You know, we were talking about return on investment versus value of investment. This is huge in the value of investment. With that, that's one side of the partnership. The next side is that we have clinical leaders within Bayhealth who will train to become faculty. They are our, I call them our rock star preceptors, and if you're a nurse, you know that person you've had in your life who's a rock star preceptor. They just naturally gravitate towards mentoring and teaching, and they are a clinical nurse. We keep that individual at the bedside, but the partnership with the University of Delaware allows us to train them to be clinical faculty. So we keep repeating the process. More faculty, more nurses, and connection and retention at Bayhealth because we have made the investment. That's the summary of the program. We are early. We do not have outcomes yet, but we will. Dr. Melnick, we will have outcomes. It is evidence-based. And we're very excited to launch that program. And Dr. Liz Speakman, she's the dean of the university, she and I are wide open for sharing the experience that we've had, if you like.
Cheryl, would you like to go next?
Thank you. I just want to preface these remarks by saying that probably everybody in this room or almost everybody in Delaware at some point in their life will need help in senior care, long-term care, home care, you name it. We will all need it. I've needed it. There'll probably be some for my family. I'll probably need it personally at some point in my life too. So we want it to be ready. We want it to be well prepared. We want it to have all the staff it needs, all the resource it needs. And because most people don't want to think about what it's like to be with your aging loved ones as maybe they're in their last living setting, we've tendency to not invest in this area where we really should. So prior to the pandemic, we had about 16,000 jobs in long-term care in Delaware. It was over $1.5 billion worth of economic activity. We're not anywhere near that yet in terms of getting our jobs back after the crisis of the pandemic, where we were at some point during that time, buildings lost 50% of their staff for all the reasons you can imagine. So we're probably closer to, on an average now, maybe 10, 12% difference in terms of what we need. And what that means is, because we have acuity staffing, both in our regulations and in the goals of these organizations, they cannot fully come back to full census and take care of as many people as they need to and as the community would like them to, until they can find the staff to fill those roles. So we're somewhere between 81 and 84% full. Before the pandemic, we were in the mid-90s in our buildings, some buildings 99%. So we need another, 10% of people. That's a lot of people. And you can't, walk out this door and create a nurse. You can't walk out this door and create an LPN. That takes time, that takes investment, that takes resources, that takes all the things we've been talking about today, support for preceptorships, you name it. So we already have a staffing mandate in Delaware. There's a federal one that's coming for long-term care that Delaware will not meet. Between 17 and 20% of the buildings will not be able to meet it currently, the one that's coming from the federal side. We have buildings that struggle to meet the one that Delaware's had in place for 25 years. Just because, like I said, we're upside down in the supply versus the demand. So those are some of the things that we're seeing in our area. We also have a dramatic increase in behavioral health needs and caring for individuals with behaviors, and I'm just gonna say behavior/dementia. They're not the same thing, but I'm just gonna put them all in one lump sum so people can understand. That takes additional training, additional resources, additional help. And whereas many of these people may start in long-term care in an assisted living environment, which is much more like you would just see like a condo or a fun place to go, and there's a lot of really wonderful enrichment there. Then it's not a medical model. Assisted living started out as a hospitality offering, actually, years ago. So it's evolved to include more medical and health resources, but it didn't start off that way. So as those people's behaviors or dementia may change over time, that may not be the best place for them to be, but there's a reluctance to leave there. That's their home. It looks like their home. It has their furniture. They may have their pets there. I mean, there's a lot of really wonderful things about that. Skilled nursing facilities are more the post-acute setting, more step-down from a hospital, more enrichment in terms of rehabilitation and medical services, some with vent units, dialysis, things like that. I mean, there's a real difference between these two. And the staffing requirements are different between these two. The needs are different between these two. But we all need to figure out, how can we provide this increased need for behaviors, dementia, both in the skills and in the personnel, so that we find the right placement, the right environment for the individual that needs it. And maybe it's a temporary, maybe they don't need it forever, maybe they need stabilization, but we need to be able to cooperate and do that. Our current licensing structure for skilled nursing facilities and assisted living facilities is set up to punish them if they try to do some of these things. There's, $1 million fines, and that they, lots of horrible financial outcomes and personal outcomes for people who are in the wrong place. So we need to do something better with that. So that's behavioral health. There is no place to discharge some of these individuals. The buildings are responsible for finding a safe discharge. Sometimes there is no safe discharge. The family is not able to care for them, or not around physically or on this, alive any longer to care for them. There is not a safe place to go for these people once they have recovered, and so they remain in one of these beds that is clogging up that system, eliminating spots for patients from Bayhealth or Christiana or Beebe to go where these folks really belong in some kind of supported senior housing environment. So we need some more resources in that direction. We also have seen, and we talked a lot about it today, and please don't take this the wrong way. I love my doctors, and I'd be nowhere without them. But Delaware has spent a lot of time and attention on our physicians, as we should. But the direct care that is being given to Delawareans is not primarily given by physicians. It's primarily given by others. And it's time that we sort of figure out that percentage and realize that we need to be spending that much more time and finding them, training them, helping them build from that, CNA medical assistant role to that LPN, from that LPN to that RN. And I'm talking on steroids. We need to have done this probably 10, 15 years ago, but it's not too late to start, right? If you don't start something, you'll never get anywhere. So we need to get that glide path happening as quickly as possible. We also have had a lot of changes in ownership in our buildings because of lack of funding and lack of Medicaid rate increases. About 65% of people, 67% of people in long-term care for the long term are Medicaid recipients. If we haven't had an ongoing rate increase to be able to deal with the costs since 2008, 2009, there's a lot of liquidity issues, and buildings have changed, and a lot of change in ownership and a lot of changes in expectations. So there's a lot there. And last but not least, while the temporary nurses age and staffing agencies have been very crucial to success at being able to meet the needs that we have in our setting, they're not the best answer for the resident. There's a lack of continuity of care there. We need to try to find whatever we can do to encourage people to make a commitment to a group of people, to a group of residents, to a facility, and that generally is funding, is a lot of the reasons why people do that. So thank you.
All right. Am I up next?
Yep.
I was following the line here. So I think one of the things that I've already heard with some of my colleagues here, or I'll call you colleagues for the day, but thank you, is really around, this idea that we need more, right? We need more of these care providers. We need to make sure that they're staying with us. I think one of the trends that we're seeing is this idea of seeking out mobility, and I don't think that's a negative thing. And if there's not the opportunity for mobility internally, then they're often looking externally. And I think that one thing that we can all agree on is that when we have the ability to have someone stay with us, that we will have improved outcomes and we will have improved success. And to echo what we've heard already, we need to give them the reasons to stay. So one thing that we continue to focus on is what retention elements can we add into our providers, our caregivers. As many of you know, ChristianaCare calls everyone a caregiver because ultimately it takes us all to provide that care. Again, value of investment. We have a lot of programs similar to my colleagues here that invest into those individuals coming into our organization. And nurse residencies are an area that we also believe very strongly in, that sets those individuals up to have that foundation. The cohorted model we have found, having someone in it with you, feeling like you have friends, feeling like you matter, that you're understood, that you're seen. Those things all really do make an impact and a difference. I'm going to call out my colleague who I'm staring at right now, and she doesn't know it. But backing it up even further is another area where we've really seen, again, we can't create a nurse overnight. And there are many different people who provide care to our patients. And those individuals, when a patient has someone walk in, they don't care what the color scrub is. They know how that person makes them feel, and that is ChristianaCare to them. And same with all of our organizations. The person who is in front of them in that moment caring for them is the person who matters. And so we have to invest into all of those caregivers. And so one of the programs that has grown over time is our patient care tech residency program. So we will take in individuals who do not have any healthcare experience, partner with local provider or education providers in our communities, and give them that experience, give them that education. And Michelle Salamo, sitting in front of me, she's done incredible work to address all of the factors that go into that. So it's not as simple as just showing up. Some of them have a lot of different barriers and challenges that make obtaining that education and integrating into these programs really challenging. And so I'm really excited. I am also a very, very data-driven individual. I might have a small reputation. I have two reputations within my friends at work. I'm the pilot queen. I will pilot almost anything to understand if there's value there. And the reason I like to pilot is because I want to gather that data so that I can make educated decisions about whether we move forward or not. If the data doesn't show that this is a strategy that's working, even if it sounded fun and exciting and it was trailblazing, if the data is not there, we stop and we move on. We've developed a mentality of fail and fail fast, right? So try new things. Don't be afraid to try those things. But this program in particular, we've now compared our patient care technicians that are coming in through a more traditional path in comparison to our patient care techs that come in through a residency. And we actually have between 10 and 13% improved retention with our residents. And that is a hugely meaningful number, and something that we are going to take back to our nurse managers, because we need them to understand the value of having these individuals come to their unit. Another reputation I have is transparency. So full transparency, in the beginning, it was difficult to get the buy-in, and that is why data is so helpful and so important to really bring to that picture. So bringing in different programs, again, to build that talent, to find a way to connect them to ChristianaCare and feel like they are like really a part of the team and they're valued here, super important. One or two other kind of connected concepts. Home health in particular. I am a nurse. I went to University of Delaware. I think some great changes have happened, over the last several years. I won't say exactly when I graduated, but things have changed since then, and clinicals start earlier, and that is really important. I think getting individuals into patient care earlier, allowing them to get jobs within our organizations earlier, be involved, be connected to these different communities. So really helping students, even in high school programs, right? Opening up these lanes, and someone talked about coming out with a medical assistant, CNA, et cetera, helping our students understand the different areas of care they can go into and not have certain areas be an afterthought. Home health needs to be one of the really common places that we are showing these individuals that they can work. Because if it's seen as, oh, well, that might be something I do down the line, they kind of forget about that idea, or they forget about that passion. So we have to show them how it is all one cohesive, trajectory of care. Because I think sometimes, even as a nurse, once they left my area, I was like, well, I don't know, they're going places, right? So I think understanding the entire way it connects from the moment they get sick, where do they go? And I'll probably touch on this later, but the right place, right time, right care, where do they go? And then where do they follow all the way through that entire line of care? And how does what I'm doing connect to that next person? And so I think there's just a lot of opportunity, again, to invest into these individuals, give them a reason to want to stay, and help them connect to the care that they're providing.
Boy, I was asked to say, what are current issues and current trends that's going on right now? And at Beebe Healthcare, and as part of my role is really working with our education workforce, it's comes down to as far as the issues, it's pretty much what everyone here experiences, right? It's shortage and burnout. Don't feel like we have enough people on burnout. Just like many other areas, Sussex County is the fastest growing county in the nation now. It's been in the top 5 or 10 now for multiple years. It's just the amount of people coming in, and we just don't have the infrastructure built in to handle it, right? Schools, dentists, physicians, nurses, home health, doesn't matter what it is, right? Roads, transportation, education, the schools, it doesn't matter. The infrastructure is just not there to handle that influx into it. And so we're all dealing with this. We could be having the same talk about the school systems, and we're talking about healthcare today, but it really is the same problem. It's uncontrolled growth. How do you really maximize that growth of where you live? Well, can't answer that question, but as far as healthcare goes, You know, we've already started to have some trends that we're doing, and I think it probably all keys and partners around the single word of partnership. The key word is partnership, right? Because you can't do it by yourself. You always hear the old adage, it takes a village. It does. In fact, it takes a county. It may take a state to do it, right? And I think that's where we have to get to, because none of us can get there alone. And if we try to get there alone, we'll either be successful in spite of everyone else then who won't be successful, which doesn't help the state, or we'll be successful together. And so we do need to partnership well together. And so the partnerships that we've looked at is probably the single biggest. Now, what I'm about to say, I am a little bit biased, because a lot's on data too, but we do have the best nursing school in the entire state, one of the best in the country, School of Nursing. And so it is, but it's that partnership with our School of Nursing. It's our partnership, you know, I work with I specifically direct our UMA, so our undergraduate medical education. And part of that is we have a great partnership, as well do many of our other systems, with the Philadelphia College of Osteopathic Medicine, and allowing us to bring back many of our Dimer students and other students who are interested and teach them and have them do their entire third or fourth years of medical school right here in Sussex County, in Newcastle County, depending on which of these campuses they go to. And at Beebe, it's great because then it allows them to see for an entire year what life can be like at the beach. It's a great draw. It's a great draw. And it allows that. The other thing that we do, of course, we've partnered with our GME program. That's our residency programs. We're kind of concentrating specifically in around the primary care. So right now we have family medicine, we're developing internal medicine, developing a psychiatric residency. Very excited about that, and also geriatric fellowships and other fellowship programs too. So in the next few years, you'll be seeing Beebe kind of putting out a lot of the stuff. So we're very excited about that, and really honing around those primary care, mental health aspects of it. But to do that, we can't do that alone. We have to partner, right? So we're working with, in our family medicine, we work with our Nemours colleagues who are able to help us care and teach our residents about those pediatric patients, that they don't get those specialty pediatric patients, because if they're admitted to Beebe and they need that specialty care, they often go up to Nemours. So we need that we need that relationship with them. With Sun Behavioral and other behavioral institutions, Rhoades has been a wonderful partner for us and our students. And even outside partnerships, the county itself and the things that are going on in the county, it's amazing when the students and the residents can get out into the programs in the county. We've also found that that also strengthens their desire to stay and keep them in the workforce. So, our School of Nursing started that idea, and that's where I learned it from, was they have their nursing students go out and give immunizations and work with our mobile health clinic and that kind of stuff. And that's the kind of thing that we like to mimic and partner with those state and the county areas. And then the last thing we do is we actually started, I started this 11 years ago now, is we've developed a leadership program for our current medical staff. It's the one thing in medical school you do not learn, is how to be a leader, how to talk, how to really lead groups, small groups, in the sense of a team. It's very different, right? When I went to medical school, it was, you're the physician, you have to be the leader, and nobody else matters, and you just got to do it, and it's wrong. It was wrong then. And so what we teach now, what we really train now is, no, how do you get that input from that team? If you have a good team working with you and you respect that team, errors go down. Less mistakes are made. So create a good team. Again, it takes a village to care for a patient. And as a physician, as we said earlier, you're not there most of the time taking care of the patient. It's everyone else who's there taking care of that patient. You need to have that team where you can work collaboratively and work together as to do that. So it's, to me, the trend that I would say, it's really about teams. It's around having nurses and residents, nurses, medical students, resident physicians, NP students, all working and learning together, so that when they get out of training, they realize that that's the way it should be. I shouldn't be isolated on an island. So,
last but not least, Sue.
Thanks. So the issues that the home care industry is facing are similar to others who have spoken today, but I want to speak specifically to what is happening in home care and some of the trends that we're seeing to address the concerns. First, Delaware's population is aging, and I just want to give a shout out for aging. Aging is a good thing. If you're not aging or getting older, you are dead. So it's okay to have an aging caucus or a caucus on aging or whatever the language is, because aging is good, ageism is not. So as the population ages, the need for home care grows, and our workforce consists of RNs and LPNs, the private duty nurses, home health aides, and personal care workers. Now, we think a lot about the elderly patients, but there's a shortage of caregivers for children with medically complex conditions who have greater care than there are nurses to provide it. Families who have children with needs for 24/7 coverage often face unfilled shifts and struggle to care for their kids themselves. There are a variety of factors contributing to the shortage. First, we've heard it here, home care is often invisible in the community, and so it isn't prioritized or funded adequately. There are some screening requirements unique to home care and also to some long-term care facilities that create barriers to employment. We don't have enough time to talk about those right now. Wages are low at all levels. Direct care workers generally earn only about 40% above minimum wage for very difficult work. In 2021, the University of Delaware Center for Research in Education and Social Policy conducted a multi-pronged survey. Some of the results showed that approximately 70% of private duty and general nurses, as they were noted in the study, expressed a belief that the PDN pay rate is not appropriate for the work provided. The survey also noted that the high cost of health insurance and lack of sick leave in some agencies were two additional factors that make becoming a private duty nurse an impossible career choice for some. Nurses reported that they were rarely encouraged by colleagues or professors and teachers to consider working in private duty nursing. Many people feel that working as a private duty nurse is less challenging, less stimulating, and more isolating than working in other settings. However, separate from the study, and in my conversations with people who are doing this work, private duty nurses who are committed to their work, especially those working with the pediatric population, believe that home care is much more challenging and rewarding as they are able to develop personal relationships with the patients and their families. They have full responsibility for the decisions and the actions that are taken. They're on their own without backup. And they have more flexibility in their schedules, which people appreciate. Some demographic trends that we're seeing, as you know, the nursing workforce, along with the rest of Delaware, is getting older. Women and people of color comprise a significant majority of the home care workforce, and nearly 1/4 of direct care workers are immigrants. So DOC and others are taking action to address these issues. First, because of aggressive, targeted, data-driven, and heartfelt advocacy, Medicaid reimbursement rates for home care private duty nursing were increased by the General Assembly in both 2021 and 2022, the first time since 2006. And Medicaid reimbursement rates for direct care workers were increased each of the past 3 legislative sessions. Prior to 2022, the last time they were raised was in 2012. We have more work to do to meet the wage demands that will enable the workforce to grow. So stay tuned for our FY 2026 public policy agenda. In response to the 2021 capacity survey that I mentioned earlier, a skilled home health nursing group sponsored by the Division of Medicaid with support from Mercer Consulting has identified and is working to implement solutions to improve the PDN and direct care workforce shortage. These include enhancing education of nursing students about home care roles with nursing schools, the Delaware Nursing Board, DOC, and home care agencies as the key partners. Promoting home care nursing careers and employment opportunities through the development of public service announcements and organizing a statewide program for high school students promoting home care opportunities and careers, similar to what others have said today. Considering the development of a home care certification for nurses, recruiting retired individuals, and developing career and educational opportunities to present to immigrant community centers. There are certainly other innovative programs that help people stay at home. Beata Home Care offers intensive in-house training, including a nurse residency program for pediatric private duty nurses. They have contracts with multiple universities in Delaware and also outside of the state to do so. Beata also has a home ICU or hospital ICU program similar to other hospital at home programs, which enables them to take patients who have been at Nemours and move them directly into home ICU settings so that they continue to get care, but in the place they want to be, at home with their families. And of course, the ChristianaCare program, and I believe Bayhealth has the hospital at home program. Those are also versions of home care that I think are very innovative. Just yesterday, there was Governor Carney signed a bill that will allow mobile integrated healthcare and community and paramedicine programs to use EMS providers to help patients better manage their healthcare needs at home, reducing 911 calls, emergency department visits, and hospital admissions or readmissions. The bottom line is that home care is critical for the health of the community, and providers and their allies are working together to ensure that our workforce is well-trained, well-compensated, and supported for their essential work.
Okay, thank you all so much. In the interest of time, so we've got about a half an hour left of this panel. I want to make sure we leave about 10 minutes for any audience questions that we have, so I'm going to combine the next two questions for you. And Cheryl, I'll start with you. Let's kind of shift our focus now to the future and what that may look like. Everybody has been talking about the impact of generative AI and what that is going to do to the healthcare industry, but especially our workforce, and how we may be able to use AI to decrease administrative burden on the workforce so that we can enhance patient care. Telehealth, which, as everyone in this room knows, pretty much everyone's strategic plan around telehealth that was 5 to 10 years out was implemented essentially overnight when the pandemic happened. Obviously, there's been some challenges and bumps along the way with that, so that's also another piece. And also the pipeline. How do we get young people more interested? Gen Z, Gen Alpha, who are children right now. For those of you who don't know, I recently learned that Gen Alpha is after Gen Z, and they're the ones that were born between 2010 and this year. So how do we get them excited about the work being in healthcare? I was at a meeting recently where a physician actually mentioned that when he was coming of age, ER was very popular. Who remembers the ER TV show from about 20 years ago? And that's what got him interested in healthcare, because it was cool to be a doctor. So I thought that was just interesting and something that maybe we don't think about in terms of just making people feel like, hey, this is a really exciting and cool thing to be a part of. So all that is to say, would appreciate you all's views on what you see the future looking like. How can we really develop innovative care models and support the workforce, and in turn, of course, better support the people that we serve? Cheryl.
Thanks, Brian. I think so. Now we need to do a hit TV show all about what we're doing together. Is that the idea? Right. In our world, since so much of what we're doing in long-term care is direct care, and you probably wouldn't want AI to do that necessarily. But there's some forms and some paperwork and some communication pieces that can be sped up by the use of that technology. And I think that's very appropriate, since there's, I thought about bringing this book in with me, but it's about that big. And it's small print, and it's just the federal regulations for skilled nursing facilities. Leaving Delaware, which is, plus some on top of that, is what these buildings have to operate. So responding to a lot of that, or answering a lot of the developing policies and implementations and responses to things, that's probably a good thing for AI. I don't know if David Bentz is still here, but if he is, I just want to go like this, because thanks to him when he was a legislator, Delaware has the telehealth that it has now. We were ready to start, the pandemic day one with telehealth because of the work of Representative Bentz and a lot of others in the General Assembly, years before anybody ever heard of COVID, or at least anybody I know has ever heard of COVID. So we have a lot to be thankful for. Also, the resources that the state has put in place for broadband and other things that have made that possible. It's not perfect, but we're certainly much better than we were years ago. We have a big problem with our workforce housing. We've talked about that. That's not an AI or a technology thing, but to the degree that we could coordinate about the investments in that, look for federal partners, look for funding, look for ways to be able to put that housing next to a long-term care facility or as part of a long-term care facility or together with our partners in home health and the hospitals. We should be cooperating on that because it's where one of our biggest obstacles to both students and new staff. Sue and I could talk about this all day, but there's a background check system in our world, similar to as you'd see in others, and there's a fingerprinting process. We're still left out of that digital fingerprinting process, and it's been going on 2 years now that everybody else has it and we don't, because we weren't considered a priority within those who have to coordinate that. And shame on them is all I can say. And I'm not going to be shy about shaming them on ignoring us, because when you don't have an easy way for somebody to get fingerprinting, they have to drive to Dover, or thankfully the Division of Healthcare Quality's opened up some spots. Drive somewhere to get fingerprinted as opposed to doing it digitally like the rest of the world, then you can lose that staff person to another place like McDonald's or Amazon. Again, nothing against them, but I'm just saying we need our fair shot at that. I think the idea of using technology in our communicating amongst all of us is where we should be thinking. On platforms that could speak to each other, as opposed to, well, we've got this great platform, but it doesn't speak to this group. Or we have a wonderful, information system, but it doesn't speak to yours. And they're all because somebody's bought that. They've sold that product. They've done something to that. So we need to try to be doing as much as possible among common platforms, so that to the degree the information doesn't have to be inputted 6 times in 6 different places. And we need to try to find out, state is way too small to have that many things operating kind of against each other when it comes to communication and information technology. Thank you.
Thank you. I'm going to take this a slightly different direction, because I think many people here are probably going to talk about the hospital care at home programs. We do have some great virtual nurses. I will shout out that. I think over 500 beds right now and more coming. And one quick comment there that I enjoy very much. I heard someone went to one of the units that traditionally is quite noisy with call bells, et cetera, and they showed up and said, what's going on here? Why is it so quiet? And the reason it was so quiet is because those patients were supported by virtual nurses, and many of their needs, their questions were being proactively managed by the virtual nurse team. And that really allows nurses to focus while they're on the unit on the care they're providing, less documentation. So much of that is great news, and it's really, I think, allowing nurses to be more present, really provide the care that we intend to provide day to day. So shout out to all the teams working on virtual nursing. And I wanted to bring in, since we are running low on time, some of the things around pipelining and just opening up recruitment for these roles. And we've talked about supply and demand. Again, retention is going to be our friend in any environment, but we've done some creative things that, again, I really enjoy, and I use data to identify. So partnering with some of our recruitment agencies, recruitment marketing agency, I should say, around relocation campaigns, really trying to identify pockets based off of economics, nursing licensure, other licensure, just organic traffic. Where are the interested pockets of people who would love to live and participate in the great state of Delaware, and how can we attract them to these opportunities so that we have the caregivers we need to provide the care across all of our organizations. Because sometimes it may feel like we're just borrowing over here to give some more over here, and I think we really genuinely need more qualified caregivers. So building them internally through some of the processes that we've discussed, and identifying how to attract them from other places. So again, using that data to understand where those pockets are living, and putting that marketing out there. Getting creative, to your point with the different generations, getting creative with the way that we do our outreach. That Gen Z really cares about our values, and again, at ChristianaCare, love and excellence drive our values and our behaviors, and that's something that actually means a lot to that group. Benefits are really important to millennials, work-life harmony. So you do have to kind of adjust, growth opportunities. What do those clinical ladders look like? Because if I can't grow in your system, I'm going to find somewhere to grow. So giving them very clear pathways for growth and success, allowing there to be mobility across different units. If this isn't working for you, how do we partner together to find somewhere in the system that is the right fit for you? But attracting those Gen Zs and even millennials still, we have learned that we need to try new things. So we're even doing some social media influencing, which is new and interesting. And really, podcast ads, we're really getting out there and just trying new things. And again, seeing if it works, looking at the outcomes and identifying, again, where we're gonna end up with a really solid candidate for a hire. Investing into technology around track to hire. So not only do we know where our candidates are coming from to click that button and say, I'm interested, but we can actually now we're just actually about to start tracking them all the way to the day that they start. So we can say, the candidates who actually started, or the caregivers at that point, where did they come from, and how do we invest more? How do we grow more? How do we make this more successful and more efficient? So a lot goes into the front end. I think sometimes, what happened when I started this role even has changed so much. And I think ChristianaCare in general has always, some people in Delaware know who we are, right? I think we're pretty well known in Delaware. So we may not need to do as much informing of our Delaware colleagues, but I kind of look at it, I used to say a donut, but I like salty over sweet, so now it's a bagel. But I look at our marketing strategy as a bit of a bagel. So that inner circle, they know us, right? We need to be present, we need to show up, but how do we reach that outer radius around our inner circle? And again, Delaware is uniquely positioned. We have New York City, Philadelphia, Baltimore, we are very close to a lot of big competitors, but how do we pull those that are in the middle into our state and help us solve those, those career needs internally? How do we give them, what they need to be invested here? And so that's kind of been a lot of our strategy in pulling in additional talent.
I'm here to tell you the future. And the future for Delaware looks great. In the future, we're going to have a medical school that'll align with all of our colleges and other schools to create really a college of health sciences, so that all of the areas we've talked about today will have those infrastructures being able to grow up into and graduate and have that workforce we need. In the future, we'll be able to use telemedicine for the right purposes, not just because I don't feel like driving or can't get to, because so often I end up seeing a patient in my office 3 days later because the telemedicine doctor didn't get a chance to examine the patient and they're sicker, and I'm sending them to the hospital now, where if we had just gotten them in sooner, it would have been easier, all right? So when used the right way, it's amazing. Also, there are a lot of visits I didn't need to see in the office that could have been telehealth. So it needs to be used the right way. And in the future, it will be. In the future, we'll be using AI. And as adequately said, it does not replace health care. But how much of what we do is due to the things that we have to do because we have to collect data to give to the payers, to justify the means of the payments, to justify the quality of care we're giving, all that stuff. It's important because the payers are paying it. They need that data. They want that data. But how much more does that put on the doctors and nurses and all of the healthcare team to collect that data. We're not operating to the top of our license. I don't want to be sitting in front of a computer. None of us want to be sitting in front of a computer typing and collecting data when I should be pushing the computer aside, looking in the eyes of the patient and listening to what's going on and caring for their needs. And in the future, AI will help us do that. AI will be able to collect that data, collect that information for us, take away the burdensome part of my job that actually adds to burnout, therefore also increasing my well-being. That's the future I want to see.
I like that future that you're predicting. I'm just going to say a couple of things about AI and home care and pass it on to Rosi. Home care providers, some are using AI for scheduling. It's great to put the care recipient together with the caregivers looking at different match factors, including geographic location. So they're already doing that, which reduces an administrative burden. AI is being used to do some risk assessment, particularly around fall prevention. And the goal, of course, is to keep people in their homes. So any data that could be put together that will identify a risk and then recommend a solution is being put to good use. And just one other thing to note is feedback for the caregivers. Clients and patients can give immediate feedback using digital tools, and the caregiver gets it right away. So one of the providers, one of our members who I spoke to said, rather than waiting for an employee of the month, that you get it a month after you perhaps have performed some great task. The customer is giving immediate feedback. The caregiver gives it immediately in their Apple Watch or in their phone or whatever, and that's very motivating and inspirational. So it's a small thing, but it's part of feeling like you matter.
I find two avenues here important to note. One is around burden reduction. That is also for the patient, for the consumer. And my favorite story is my 86-year-old retired engineer dad who shops online for his healthcare. He will not schedule with a clinician unless he can schedule online, and he uploads his EKG to his cardiologist before his appointment. And the point in that is what can be done to protect the interaction that is necessary, the humanness, protecting that humanness, I think is very important. And we have a lot of options that we have not yet explored to unburden our workforce with the use of tools. Additionally, though, I think actually AI is helping to sustain or grow the workforce. And here's why. We have nurses who would otherwise be out of the industry if they did not have the option to provide virtual care. They have some restriction that does not allow them in a traditional environment, and they can still be a part of the care team. So what of our technology platform can actually engage its own workforce? Again, to the point of unburdening the system so that we can open the opportunities to provide more care.
Great, thank you. So we'll spend about the next 5 minutes on the final question before opening it up to the audience. And I'll just allow anyone that wants to chime in here without going in order per se. But how do we, we all have our individual challenges within our organizations, our industries. We've talked a lot about that today, even this morning at the other panels. What are your thoughts on how we can better work together to leverage each other? Because in one way, some shape or form, we all depend on each other in different ways, right, throughout the continuum. So how can we be better about working together in that respect on workforce efforts and really everything else as well? And then also, how can we translate that into our advocacy, especially for those of us that are in Dover a lot, Cheryl and Sue and many others in this room, with the new administration, new federal folks, new legislators, to translate that into meaningful action as we look toward the future that we just talked about.
Well, I'll just say a couple of words. To the degree that we can, we need to try to be speaking from a similar song sheet, as I said earlier. Our issues are very similar. Our needs are very similar. There's some great ideas we've heard today on ways to be able to, make changes, make positive improvements. I think we need to embrace those. Other states have some really good ideas. A lot of it may have to do with relooking at how we've done something for year after year after year after year after year, and then, when you're in the regulatory world, and you have a hammer, everything is a nail. So there's another regulation, there's another piece, without looking at, okay, what has changed in all those years about that environment, and how can we streamline some of that so that more time can be spent on care. Working together means communicating in a way that we did during the pandemic in a crisis. We did kind of on some planning issues prior to the pandemic. Our organization, ChristianaCare, and others had a Transitions of Care regular meeting where we just kind of talked over the bumps in the road. But I think we need to do the same thing with our government representatives, our legislative authorities, our policymakers, and open up that audience to all of them, because everybody probably has a very similar list of things that are the barriers to improvement. And if we've got enough people together that can work on it together, like I said before, it's a very small state, we should be able to achieve some solutions to some of those problems.
I was thinking about this earlier, and I thought, the slide our keynote speaker gave it, get rid of the stupid stuff, which is great, right? And so I think where we really, with so much of a transition in our government in the state for this coming year, I think just simply focusing on that, we get in our way so much, as we've heard many times and many speakers talk about, and there are some things we can streamline and smooth out, right? It is very difficult. The credentialing process is onerous. It's awful for all different types of specialties. And we hear it from applicants all the time. It's like, why does it take, 4 months with you guys, and it takes, 3 weeks at this state, and so on and so forth. And it is different for each specialty, that whole process. So anything that can be done. There's so many other layers of bureaucracy that's been placed throughout the years, which may at one time been very needed and very useful, but has become now more of a hindrance. We can start looking at getting rid of those things and start working on those things, and also creating where needed, when you need legislative help in this, is create the ability to have those partnerships. Because in some ways we have to be competitive partners, right? Because in many areas we compete with each other. Many of our institutions and groups compete with, but we have to be partners to make it work. So yeah, competitive partners is where we need to bring it through. So, and in some ways we'll need certain help from our legislators to pull down some barriers to make that happen as well. So I see us all, if we can work and educate with the incoming government that's coming through, that would be where I would take it.
I find myself going to the concept of onboarding. When you start as a nurse, and my HR team is right here. When you start as a nurse, you onboard. You have an orientation. There is a time period where you're shown what are the ins and outs. What do I need to know? What do I do when I don't know something? I think there's some value in an actual orientation of new team members, new legislators, because if we're not sharing the detail of what is going on, then they are not informed. And what are the opportunities that we have to do that? I think of some recent pharmacy legislation, and some of our team members at Bayhealth being very consistent and persistent about sharing what are the issues, what is the benefit, and to some who would not have had that information if we didn't take the opportunity to share it with them. So I find myself going back to, we're going to have new leaders. How do we connect early and say, here, come in and let us show you, let us orient you to what is healthcare in Delaware.
Just add to that educating about the continuum of services and starting at the basic level and moving to the most acute is important. And just Another thing about collaboration, which also could be part of an advocacy agenda, I'm not sure exactly how, is working together on what our lunchtime keynote speaker talked about, and that's just mental wellness and overall well-being for our workforce. I know that for home care providers, many of them are operating as competitive partners, but don't have the capacity to have their own in-house wellness programs. In preparation, I looked at ChristianaCare's website and saw the wonderful wellness resources there, and the fact that Christiana consults with other companies to help them develop that. Well, wouldn't it be wonderful if for smaller providers we could have some way that Christiana or Beebe or Bayhealth or whomever came and provided those resources for members of our association, because the threat of burnout, depression, suicide is so real, and so that's just one of the ways that I think we could collaborate.
Yeah, I did forget to add, as part of my prognostication was that everyone would have good wellness and our wellness rates would drop down to less than 3%. So, sorry, forgot that one.
Awesome. Competitive partners, I like it. Okay, so with that, now let's open it up to the audience. Does anyone have any questions for any or all of our panelists? Any takers? Oh, we've got one over here.
Hi, Ben Wong again. I want to know whether any of the organizations here considering a residency on complex care, because a lot of times the patients, I know I have a lot of neighbors that have complex issues, that they go from hospital to home care to home to long-term care and back. And I know Boston has a residency program on that.
Yeah, I'll take this one. So I know at Beebe Healthcare, but I also know at all of the other residency programs. So this is true for both all of the residency programs in the state, actually. A lot of the new requirements, you brought up a great point, by the way. So a lot of the new requirements, especially for the family medicine residency program and internal medicine residency program, is both two things, really. It's caring of the complex patient and geriatric care specifically, which really is where that comes into play a lot. I know they actually have that in the pediatric realm too, for the care of the complex pediatric patient. And the other thing is the transition piece. There's actually a lot of new requirements. In fact, the American Board, the ACGME Family Medicine are actually altering their requirements right now. And one of the proposed requirements is all about adding the transition of care piece to make it even more robust. So it's, yes, and it's actually seen nationally, and it's being a part of the requirements in your residency programs. So at least I know that part of it, though.
Okay. Thank you. We have another one? Take your time.
This has been a wonderful day. I'm Veronica Wilbur, and I'm a family nurse practitioner of 30 years, and I have my own practice for the last 5 years. Insanely, I started it when I was 58. I'm now 66. But this is a lot of institution stuff. And so what I'd like to know or hear from panels, or at least have some consideration, is those of us, there is a lot of independent nurse practitioners out there. We aren't owned by anybody. We don't really want to be honest. But we are lost in this whole conversation. And there's all these social determinants of health that I have to struggle with in trying to help my patients every day that could probably be another whole conference, such as logistics, such as transportation, such as how do we interact with the other pieces of that. And that could, like I said, could be another whole conference. But again, there's a feeling, and I don't know if anybody else in the audience, there's a feeling of being left out. We're not part of an institution, but we are expected to be partners in care, and I have very loyal patients. And there's so often when somebody in a specialty wants to say something and they say something to my patient, oh, I can't do that. go see your PCP. I hear that more often. Plus, the communication is extremely poor and lacking. I have to guess when my patients, and I'm sure others do too, I have to guess when my patients go to the hospital. So you just talked about transition of care. Well, I have to guess when they go, or if the patient calls me to tell me when they go. So if there's new regs that I have to follow, it's going to be not lots of more fun than it is now. Just there's lots of little pieces that as bigger institutions, and you guys are all doing a great job. You know, actually, I consider myself a honorary Delawarean, but I live in Pennsylvania and sleep there, and I work in Delaware, and I've been here since 1976, and I worked at Christiana. So anyway, those are just some thoughts that have been going through my head all day, and just how can we, you talk about collaboration, and it's all collaboration within your little silos. How do you collaborate with the outside silos that need to be part of this party, this conversation? I get shut out of a lot of committees because I live in Pennsylvania. It's seen as, oh, you're not a Delawarean, you don't get to be. I can't be on committees, and I've actually had this happen to me more than once. And it's mainly because I'm not a Delawarean by land, like a house in Delaware. So anyway, those are just some of my thoughts, and just if anybody else has anything like that, just like to hear what you think.
Thank you. Yep.
I just have a quick comment. First, the work that you're doing to take care of patients is very important, so please don't stop. Definitely. I didn't think for a moment that you would. However, I just want to clarify that work is very, very important, and I appreciate the introduction of what is a longer conversation. I think the common denominator, though, is care for a community member, care for a patient. And there are intersections where we can collaborate, and I think that any health system would be more than willing to be shown a door that needs to open and allow us to make that connection. So I'm really glad you made that point. Thank you.